Welcome, everybody, to the first meeting of the Special Legislative Commissions to study the impact of insurance payments and access to health care. So I have to confess that I'm a little less prepared than I would have been because every time I get in the car, I can't get away from the radio, which I have tuned to certain national news that... and I want to get that 5-minute segment in, and so I haven't been able to maybe quite prepare as I would have. But so I want to go through a little bit of how we got here today and what I think we can examine as we are here today. So the ambition would be to have a comprehensive review of health insurance payments for medical, dental, mental health services to determine if the current payments impact the state's health insurer network adequacy and appropriate access to health care to Rhode Islanders. And that's like as brief as I could put, like a comprehensive statement about what we may or may not be able to cover in the course of potentially 4 meetings, possibly 5. And but from a personal perspective, as chair of the Health and Human Services Committee, and I know I don't want to speak for Senator DePalma, but I know he's had some of this experience as the chair of in the Finance Committee over these issues, is that a lot of information on whether or not reimbursement rates are adequate to actually create a comprehensive network of care in Rhode Island has been presented, at least to us as chairs or committee members over the course of many years, as anecdotal without a lot of data behind those anecdotes. And some of the anecdotes collectively in our minds bring us to conclusions that we are hard to dispute but don't have a lot of evidence and don't have a lot of presentation that's made with any structure. And so what we hope to get out of a commission like this is to collect the anecdotal, if that's part of what we do, and add a level of data to that to support or dispute what we have arrived at as through our many years of anecdotal presentation of how care in Rhode Island and care in Rhode Island generally, whether you're a provider, a payer, or a government entity, is impacted by the reimbursement rate. And at least to me, that's the importance of doing this, is that we need to move beyond what we have done in, I wouldn't say arbitrary, but in a way that we can't act formally on. And we can't act formally on the way we were being presented information to this point. I think one of the tasks of a commission like this is to prioritize what we hear and what we can act on. And so there are many levels, and I only said a few of them in the opening sentence on this, is we can attack this on, or approach it on how it impacts behavioral health services. We can approach this on how it impacts hospital mergers. We can approach this on how it impacts agencies such as DCYF, and we can approach this on how it impacts a lot of different systems that interact with healthcare in Rhode Island, and so it becomes an interesting task and discussion for those around the table, but it's not easy for us to follow up on unless we prioritize. So one of the things as we get into a discussion, a more open discussion amongst members, is how you would prioritize and what you would like to either present or demonstrate on why that is a priority. So we do have one presentation today from Dr. Sarkar, but before we get to that, I want everybody to introduce themselves and if they have a perspective that they want to get into, but we could get into that later, so there will be time to do that, and start with Senator DePalma.
Thank you, Chairman. It's great to be members of Since I joined the Senate, sorry, I should. Having served on the Senate Finance Committee since joining the Senate in 2009, and I think I was subcommittee chair the first year, I think, or somewhere thereafter. So about 11 years, subcommittee chair for Health and Human Services. We've seen this issue present itself, and we've seen the issue magnify itself over the years. And as Senator Miller indicates, and Chairman Connolly in Finance, and many hearings we have are health and finance. They're one and the same. You can't talk one without the other, because they do go hand in hand. And what we've come to realize, and you folks know this in spades, so I'm not telling you anything you don't already know, but having worked quite a bit with Sue and some of the work with the mental health centers, spend a lot of time on the DD side of the world these days, the commission area that we're about to have some recommendations coming out. DCYF, another area, there are rates and there are costs, right? There are reimbursement rates and costs. And somebody said, well, aren't they the same? And they're categorically not. Typically, the reimbursement rates are below the costs. How can that be? Well, it is because that's what the state does. It just is. We don't have to like it. So we have to figure out, how do we change that? How do we have the dialogue and the education and communicate that to legislators, to the federal public about reimbursement rates? So it costs you $8 and we're giving you $6. Yes. So we have inflators in the case of nursing homes. We have annual inflators in there. And in fact, one of the folks in the Senate Fiscal Office has done the analysis. It's all online. You look at the last 10 years of what the adjuster was by Medicaid, and you all, folks all know this. You go to CMS and you can look at what the Medicaid adjuster is for, 30 years? 2004 to 2034, or some number of years. And we met it, I think, twice over the last 10 years. So there's some issues there we have to address. So it's important about the rates and the costs. So we have to bring this thing back to, I think, hopefully talking about costs and how that impacts it. One thing we've seen on the mental health side of things is the reimbursement rate is below the costs. So we've caused some strain, I'll say a lot of strain, on some of the providers. So this, I'm just picking that one out because we've had a lot of focus on that over the years, but it applies to many others. So we're going to get to the point, we hope we never get to the point where one of the providers is going to say, Uncle, I'm done. I can't do this anymore. Then what are we going to do? Which gets me to the third piece. We look for services and capacity in the state of Rhode Island. We want services in the state of Rhode Island where it makes sense, where there's the economies of scale. The one-ofs, we need to figure out something different. But when we don't have the capacity, we're willing to have somebody go out of state for 4 times the cost. Because potentially the service is not provided in Rhode Island because the reimbursement rate is so below the cost. So the services are mandated. It's part of somebody who's a entitlement. So we're going to get that service out of state and maybe pay 3 or 4 times what that cost is. We'll look at this holistically. I think we'll address that. And I'm going to start where I end where I started. I'm glad to be a member of this commission. I think we're going to do some great work and figure out what we do in the next N number of months and what we do long term. So thank you. More than just an introduction, I guess.
My name is Dr. David Kressler. I am a psychiatrist and a provider. I'm the medical director of the largest psychiatric private practice in the state. We do accept insurances. We do contract with the insurance companies. I hope we can use psychiatry, behavioral health, and mental health synonymously during this commission. So it kind of makes sense. I'm happy to be part of this commission.
Thank you. Thanks. I'm Marie Ghanem, Office of the Health Insurance Commissioner, and certainly this is an issue that comes up often in our world.
I'm John Bonin. I'm the Medicaid Chief of Staff representing EOHHS today. Senator, thanks for having us. And as the Commissioner said, I mean, this is vital to us as well, as ensuring access to quality care for all our members is critically important for us. So thank you for having us on this commission.
Good afternoon. I'm Tom Chase. I'm the Chief Operating Officer for Dental of Rhode Island, so thank you for having us on this commission. We're excited to participate and bring whatever expertise we can to the table.
Hi, I'm Susan Storti. I'm the President and CEO of the Substance Use and Mental Health Leadership Council of Rhode Island. Thank you, Chairman Miller, for inviting me to be a part of this. I would like to just piggyback on to some of the comments that Senator DePalma made. While understanding that cost and rate are vitally important to ICSIM as well as service capacity, I would also like to bring in the component of quality. And to provide quality care, you often hear about the need for the practice of evidence-based practice, which then goes back around to the rate in which organizations are reimbursed for the provision of those services and who can provide those services, so that then it becomes a workforce issue as well. So I would just say I think that however we examine this holistically, that we also need to make sure that quality is a piece of it. Thank you.
Stephanie Dubrew, I'm with United Healthcare. Thank you for including us in this commission. I want to say that we're pleased to be a part of this, as we are with some of the other state initiatives that have been very successful in improving access, so thank you for inviting us.
It did it, and then it didn't do it. Lisa Tommaso, I'm the Vice President of Strategy and Public Relations for the Hospital Association of Rhode Island. We are very pleased to be part of this conversation. We have probably engaged in conversations with most folks sitting at the table today regarding rates. The thing that I would like to bring to your attention is that while we are the Hospital Association of Rhode Island and we do represent hospitals, it is important to remember that our hospitals are actually health systems in Rhode Island, and they represent some of the other providers that we are here talking about for reimbursement rates. So for us, it's not just a concern about how our hospitals are reimbursed, but also how the community providers are reimbursed as well.
And Linda, you're up.
Okay. Hi, I'm Linda Hurley. I'm the President and CEO of CODAC Behavioral Healthcare. CODAC, for those of you that don't know, we're a provider of substance use, behavioral health, and medical treatment. 83% of our patients are publicly funded Medicaid or managed care, and we actually serve over 47% of those receiving medication-assisted treatment utilizing methadone in the state right now. So we are, due to the current epidemic of not just opioid but other substance use disorder and related behavioral health care issues, really stretched. And and also Senator Miller, thank you so much for including CODAC's voice, including me in this. What I envision and hope for is that we will indeed have a conversation relative to rates, and that conversation has many subtopics. One thing I would be happy to offer is I received the Medicaid rates for Connecticut and Massachusetts and created a spreadsheet for comparison for others that have looked at our rate issue, and I would be happy to share that with this commission. The second piece is we have an interest in closing the gap between the point of service and the related payment. That takes us to the third piece, how that impacts workforce, and then what Dr. Storti just referenced. And when that begins to impact workforce, that impacts quality, competence, and capacity. So I will be, actually, Senator, I have a lot of this written already, so I would be happy to provide that rather than have our time spent on details, because you had referenced that the anecdotal is great, but what really is needed here is fact. So thank you. And data.
Good afternoon, everyone. Thank you, Chairman Miller, for including the Health Center Association in the commission. My name is Jane Hayward. I'm the president and CEO of the Health Center Association. We represent the 8 federally qualified health centers who take care of about 118,000 Rhode Islanders here. And we do that in terms of providing primary care, behavioral health services, and oral health services. I would say that probably our largest access issues are 2. One is behavioral health, continues to be, along with our colleagues around the table, and secondly is dental. And I'm happy to speak more about the dental access issue as we go on.
There we go. Good afternoon. I'm delighted to be here, Chairman Miller. Thank you so much for the opportunity to participate in this panel. My name is Neel Sarkar. I am on the faculty at Brown University in both the School of Medicine as well as in the School of Public Health, and I'm currently serving as the interim president and CEO of the Rhode Island Quality Institute. And I hope that as part of this commission, we really do get into some of the data. I think this is a really exciting time for all of us to look at a question like this. I think it's going to be the beginning of really showing the value of many of the investments that we have made as a state in generating data, using data, and now actually taking some of that data and putting it to practical use. You'll hear more from me momentarily.
Hi, I'm Noah Benedict from Rhode Island Primary Care Physicians Corporation. I'm the Chief Operating Officer. We represent about 150 primary care physicians throughout the state, manage the care and the wellness for approximately 150,000 Rhode Islanders. I'm here and excited to be invited to this, so I thank you for that, because we have some significant challenges as it relates to access to care, especially for Medicaid beneficiaries. A lot of our independent providers, with the launch of the ACA, took on greater amounts of larger panels of Medicaid lives. And then when that 100% of Medicare reimbursement for those initial 2 years went away, it returned to the roughly between 40 to 55% of the Medicare fee-for-service schedule for those payments to see those same patients. And as Susan has stated, I would say reimbursement rate and quality do go hand in hand. And since that time, we've had a number of providers drop out of many plans, many MCOs, and do not take Medicaid any longer. And we really foresee what is going to be an access crisis within the community independent providers. And we roughly care for about half of those Medicaid lives in the state. So really excited to be part of this conversation and hopefully make some progress.
There you go. Hi, I'm Monica Osceola, Vice President of Legal Affairs and Policy at Blue Cross and Blue Shield of Rhode Island. Thank you, Senator, for having us here. We look forward to being a resource to the group and helping to answer any questions you might have.
So I do want to say that before we get to Dr. Sarkar's presentation and then have a further discussion, that we felt it was very important to have both payers and providers participate in here, and you might notice that we have 2 of Rhode Island's largest payers at the table, but we made sure and specifically reached out to the other payers in the state because we thought it was very important that they also feel that they are free to participate if they don't feel like the 2 payers at the table are representing issues that are important to all payers. So we do feel that they will participate if they feel that they have an issue that hasn't been addressed by those who are here. I want to get to Dr. Sarkar's presentation, and then we can have further discussion from members of the panel or the commission. And I do want to explain why we're all crammed around this table. In this room, as you do know, we're making repairs to other part of the building, which might accommodate a little larger table. And this room has its issues for me, especially in that there's a hierarchy created by this, which I didn't feel led itself to a good discussion amongst commission members. So therefore, if you're wondering about how we're arranged today. That was at least my goal, is to facilitate discussion rather than to create a hierarchy, which the rest of the room seems to do. With that, getting to Dr. Sarkar, for those of you who don't know, he was selected as the interim president and CEO by Rhode Island Quality Institute Board of Directors earlier this year. He is also the founding director of the Brown Center for Biomedical Informatics, is the associate professor of medical science and associate professor of health services, policy, and practice at Brown University. Prior to his current roles, he was assistant professor and the director of biomedical informatics at the University of Vermont, leading informatics activities that supported nationally recognized programs. An internationally recognized leader in the field of biomedical informatics, Dr. Sarkar has authored over 100 peer-reviewed articles and has earned his PhD in biomedical informatics at Columbia University and his master's in librarian information science with specialization in digital libraries from Syracuse University. So go right ahead.
Sure. So this is always going to happen to the tech guy, right? So tech issues.
I'm sorry.
That's all right. There we go. All right. And where do I go?
The start menu on the bottom. They should. Should be. I thought they said they had I apologize. Is that your USB?
No.
Yeah, they should be on the computer.
Okay. I can just talk while we sort out the PowerPoint. Yeah, it's just.
I'm sorry, I'm like halfway.
All right, do you mind if I borrow it? Yeah, that's great. Okay. No. So there's only one slide in here that actually matters. So while I talk through slide 1, we will hopefully identify where the actual presentation is. And so, as I was alluding to in my opening remarks, this is a really opportune time for us here in Rhode Island, where we have major resources that permit us to really get into some of the data. And there's a couple of different resources that we could use. And in an earlier meeting with Senator Miller, we agreed that a place to start would be to look at our all payers claim database. And acknowledging that no database is perfect or complete, and there are a number of data challenges that one will undoubtedly encounter, the APCD, or affectionately known locally as the Health Facts RI, is a great place for us to begin this conversation. And so that's where I'll start with my analysis. And then I would urge us to also remind ourselves the limitation of claims-based analyses. And claims-based analyses are what happened and what was paid for. But it's not all of what was all of what happened, and it's not all of what was paid for, because a lot of the costs just don't appear in claims by the nature of healthcare. And some of those are hidden things, hidden items that really actually essentially stay sequestered in the clinical data. Now, to get into the clinical data, we don't have that kind of time, I think, even over the next few months, because the clinical data are going to involve going into something like a health information exchange or to a large provider and sort of navigating, for lack of a better description, very messy and unlinked clinical artifacts that are a reflection of care. So the APCD is going to be a place for us to start, and what we decided to begin with was looking at the total costs associated with a given diagnosis. And the way that we thought about this was, when an individual has a primary diagnosis of X, what is the total cost incurred by that individual that then sort of gets to the complexity of healthcare. Because as anyone who works in healthcare knows, patients aren't just one diagnosis. And especially in complex conditions, diagnoses can actually multiply, and multiple comorbidities and readmissions and all sort of come together. And so there's this complex of comorbidities that come together to make this a very complex cost. And so at least as a first step, what I will be showing you today is sort of the top ranked conditions that we are seeing from the APCD, and this is literally hot off the press. We first had to get permission to use the data, and we went through the paperwork as fast as we could last week, got permission to access it Monday, and I have been working pretty much around the clock until last night when I actually got the computer to spit out some numbers. And so I will state that as a caveat to say these numbers aren't final, they're not perfect, but I think what we will see is not too surprising. And so, oh, and it's animating for me, that's lovely. Okay. So that's what I mean by we'll be looking at the total cost. This will be a place for us to start. Now, for anyone who's done claim-based analyses, you will know there's this thing called ICD, so the International Classification of Disease and Death. 9 or 10, we're mostly in the 10 phase now where we're using ICD-10. And the CM is a very American thing because we use it to be associated with medical billing. And so it's the clinical modification of the international classification. AHRQ provides a tool that allows us to take groups of ICD codes and basically bundle them into large sets. So while ICD-9 had a good number of codes, ICD-10 has very many number of codes because it gets down to the specificity, which is sometimes important clinically, but at least for us to begin a conversation, we just want to know, is it a cardiovascular condition? Is it a neurodegenerative disorder? Bundle those together, and that's what the CCS allows us to do. And so that's what I'll be showing you today is the CCS categories that are essentially the top 10, and then looking at 5 years of data, and then take the average of where various groups of conditions fall and use that at least as a place to start a discussion over the conditions that we might start with. And what I would suggest that we talk about as a commission is let's pick one, maybe two, of these major categories to sort of work out a pipeline, a process of how we want to look at the data. Because one thing that I think was sort of behind all of our comments is we all want to make healthcare better. We all want to make it more efficient. We want to improve quality, but there's not a lot of money, ultimately. There's a limited amount of resources, and so how do we identify where the resources that we have are best placed to have the biggest impact? And so focusing on one condition, working out the pipeline, the general parameters, basically what we in geek speak call the model that we want to derive. And so do that for one, and then once we agree on at least how that is structured, I can then run that against definitely the top 10, and perhaps there's 500 or so some different individual conditions that we could do. And so at the end of this, at the end of our time together formally, my goal would be for us to have such a model for all of the conditions that we see in our state, so that while we will be focused on certain ones as exemplars, by the end we will have the opportunity for the work to continue on other conditions. And so the numbers, please, right? So drum roll. And so, as I said, so on the far left, there are the various CCS conditions. I can't take credit for how they're spelled or even the groupings that we can blame our friends at AHRQ. But no surprises, really. And so, we could have probably gone and used anecdotes to say, well, so what's the most expensive conditions that have costs associated with individuals? Sepsis, no surprise, actually. And actually, as a sepsis survivor, I can tell you that the after costs of sepsis can be pretty pretty impactful, not just from a cost perspective, but also from a patient perspective. It can be challenging. So septicemia takes the top one, and for anyone who works in clinical arenas will know that it's sepsis and early detection of sepsis. And so if you detect sepsis later in the process, especially in a hospital setting, the costs skyrocket as you get closer and closer, because actually getting the antibiotics to work can sometimes take longer than one would like. Second are neurodevelopmental disorders. And so these, again, not surprising, given some of the conversation that we're having here. And I really appreciate the principle of maybe bundling as many of the neuropsychiatric and neurodevelopment disorders with behavioral. I mean, there's some challenges with that, but I think at least it's a place to start to say these are important. And so, yeah, please.
Disorders would be under neurodevelopment.
Neurodevelopment and neurocognitive, so they're broken up actually in here according to 2. And so this is one of the things that we might want to look at. And so like I said, I really only had between Monday and today to look at this, and so I just went quickly. I think as a next step would be I'll share the CCS encodings with the group so we can look at how they're bundling things, and we can decide if there's a bundle that makes more sense for us. But neurodegenerative disorders, then cancer, chronic kidney disease, osteoarthritis, hypertension, neurocognitive disorders, spinal injuries, cardiac conditions, childbirth, and then heart attacks and COPD. So these are the top 10 things that come up with at a first scan of the database. And like I said, I don't, at least from my view, none of this is really surprising, except to note that there is now actual data to actually back up some of our claims.
Doctor,
yeah,
if I may.
Please.
This is a ranking of affliction, disease by cost.
Disease by cost, yeah. And so what you're looking at here, so the first column is the condition. And then per year is its relative
by
rank
cost
in that overall, so where it fell. So the most expensive thing in years 2017, 2018, and 2019 in terms of total costs was septicemia. Exactly. It was rank 4 in 2016. And so that's what you're seeing across there. And I just took a simple average. So
you have cost you can put for the next column? If we wanted to see a column for cost.
I could see the cost, yeah.
Maybe by just to get an appreciation for because at the end of the day, it might be number 1, but if it's got a low cost, I'm going to go tackle number 4 first. If it's number 4, if it's got extremely high costs, what do you potentially look at? But these are just the costs. These are just the top 10 conditions.
These are just the top 10 conditions by cost.
Okay.
And I do have the data. We can go into it. There's a little bit of data, and then we can actually decide how we want to do that. We can do it either as a whole set of conditions, or even within each of these, there are some conditions, diagnoses that actually cost more than others. And so a hospital-based septicemia costs more than a septicemia that was, and so we'll be able to sort of zoom in on that.
So just to follow up with regards to having met with Laura Adams in the past, regarding what they were looking at and some limitations on access to the all-payer claims database, whether somebody in Medicaid was in by choice or out by exception or whatever, and there's some other things that EOHHS was looking at. Were there 300,000 folks that are in APCD?
No, so...
What part of the population are we missing?
No, so the APCD is all claims. There is an opt-out option, but it is all claims regardless of where... and what's also from all major payers.
But somebody has to approve that. I have to approve being in the APCD.
No, that's current care. That's current care, I think. And so, yeah. And so the APCD is the insurance claims. Current care is the clinical data, and that has about half the state's population. We are actually, which may be the next question is, can you link the two? We're looking at how we would actually at least be able to identify a way for linking individuals who are in current care to this, because then you get the true before and after, or during and after. Yeah.
Just a follow-up question on cost. Is it cost per course of treatment or total cost within the APCD?
Total cost within the APCD.
So statewide. So there's an element of volume here.
There's definitely volume. We can also score it by volume as well.
Okay.
And what's also important here, and where I think for us to get a holistic view, is it's not really just one episode of care. As humans, we live past an episode of care, and then what happens next? And we know clinically that what happens to you in one episode of care will have impact on you later. And so using this as a way to say, someone who has had sepsis, for example, as the top item here, there are things that happen to that individual later that actually may be impacted by the fact that individual had sepsis. And then there's going to be types of comorbidities that we'll want to look at in detail. So for example, what's the impact of behavioral health for populations that have had this as their sort of one of their primary conditions? And I didn't have the compute power or the time between Monday and today to look at all conditions. This is only the primary condition that was associated with a given claim.
Just going to the doctor's question about neurodevelopment disorders, and then you have neurocognitive disorders. Can you give us an idea of the difference as far as what goes under what category?
Sure. So neurodevelopment is things like adolescent development.
Okay.
So adolescent issues that an individual may have as they're sort of going through, whereas neurocognitive disorders are things like Alzheimer's disease.
Okay.
So that's sort of, and they're, I guess that's the easiest way to think about it is one is your progression to adulthood and the other
Right.
is the decline.
Okay. So
Yeah.
I would assume, and correct me if I'm wrong, that these are expensive because of the amount of hospitalization it might cost.
I would
or might be
presume so.
involved
I
in
would
it.
presume so.
So,
yeah.
so one of the things that we have accumulated as part of what we want to look at based on our history as legislators, at least the two of us who are legislators here, is our ability to do something that'll make a difference legislatively. And a lot of what that leads us to is Medicaid rates. And a lot of the reason we're at the table is because of Medicaid rates. And a lot of what we have heard anecdotally, to get back to how this is useful, and it is useful, is for two things. One is that Medicaid realm and how it leads or discourages hospitalization and therefore increases costs. Mm-hmm. And the other thing is I was spent a half day at Brown. I believe you were part of that half day at Brown. Mm-hmm. And it's a whole nother realm of what we could or couldn't discuss at this is both access to outpatient and inpatient care, but the impact to mergers and the impact to specialty care within the state, or that people are going out of state for that care. And interesting anecdote at the end of this meeting, which was, or a half day at Brown Medical School, was the dean of the medical school saying one of our major hurdles is Rhode Island's reimbursement rates for many specialties, and he went on to go through a range of some of those specialties, and it's Dr. Ghanem is looking at me like I'm already overreaching. I can see that look. Yeah, and it just depends on which specialties, right? But it's still an overwhelming school of the medical. It's an overwhelming concern of the medical school, and when they're asked from the rest of the general public on what one of their hurdles is, and they say that one of the major hurdles is Rhode Island's reimbursement rates. But going back to how this data can be useful to us, it's what leads to the use of inpatient, and why do we have the use of inpatient versus the use of outpatient. And as part of that, the reimbursement rate for the outpatient. And so how much of that data will be useful to us in getting down to that level of what we might be interested in?
Yeah, and I think that's going to be the logical next step for us.
Yeah.
And so let me lay out just a little bit of a roadmap.
Yeah.
So,
I'm sorry, can I just ask
please.
a clarifying question, because it was a follow-up on Senator DePalma's inquiry about what type of data we're looking at. And so when you refer to the all payers claims database and you said that it's all payers, for a long time, we've had discussion about whether or not our self-insured are the ones who are in or out of reporting. And so self-insureds actually represent 50% of the covered lives in the state of Rhode Island. And so while if we are having a conversation about Medicaid, certainly 100% or near 100% would be included in that claims database. But I would just need clarification from you and confirmation that in fact we're looking at 100% of all claims, or are we looking at near 100% of Medicaid, and then we may only be looking at approximately 50% of covered insured lives overall?
Yeah, I can't take credit for the term all payers claim data.
Yes,
term.
but I think that's
But you're
what
absolutely
Senator
right. And
DePalma was getting
that was what
at.
I was sort of getting at before too, is that, you know, there's limitations to this. And even though it says all, there's various groups that aren't represented, but it's still a good place for us to start the conversation. So with that, I think looking at this now from the procedures that were done for individuals and where those procedures were done, build out a clinical trajectory for individuals and actually sort of as much of a life course as we can get our hands on. So this is 5 years basically of data that we can look at. And so for an individual who is in the database, what's their life course? Or an average individual who gets a particular primary care primary diagnosis, what's their clinical trajectory through the system? And so when we do that, we'll then be able to analyze what's called the multimorbidities, so the comorbidities that are interacting with each other. So some of my previous work has shown that there are what are called risk indices. Perhaps the most well-known is something called the Charleston Comorbidity Index, which was designed in the Upper East Side of Manhattan by Mary Charleston. Is a great place to start in terms of trying to determine someone's frailty, but misses some of the things that when it comes down to actually really clinically impactful. And so some of my previous work has actually gone through and analyzed, if you had 10 comorbidities, you're looking at this patient and this patient has 10 comorbidities, what are the 3 that you as a clinician have to focus your energy on? Because if you don't focus your energy on those 3 right now, the costs are going to skyrocket and the clinical complexity of that case is going to become almost untenable as we go forward. And so being able to detect that from this is one way to identify the costs. And then finally, to Chairman Miller's earlier point, is who is doing that care and where is that care being done? And so we actually can look at the provider types through something what's called a taxonomy code. So we can look at a provider type, primary care, specialist type, and then combine that with where that service was given, and then actually say, for a common condition, that's why I want us to focus on 1 or 2 conditions that we want to look at, we can say, how do we want to look at this data? And the way could be at each time point, or average time point for a individual, how often is that seen in inpatient, how often is that seen in an outpatient setting, and then what kind of provider are they seeing, and how does that actually impact the overall clinical outcome? Because my personal view is that our goal shouldn't be just to reduce the cost outright, because if we just do that, we'll reduce the quality. But making sure that the investments that we make early on, if we can at least model out the clinical trajectory that might bend the curve just a little bit, and so providing a little bit more care earlier in the clinical trajectory by the right type of provider in the most economically reasonable context may have the most impact, for example.
What would be interesting is to see cohort with primary care based upon the claims and without primary care, whether it be in the FQHC or community setting, and see what the differential is in the cost. Assuming that it would probably be much less if you going to primary care and getting your referrals, it would probably be much more, but it would be interesting to see that. Because from our perspective, we would definitely want our members, whether they be Medicaid, Medicare coming in, to see their primary care doc, even in this very PPO-dominated market. And we want to make sure, especially in Medicaid, that docs are accepting patients and that they are guiding them through the system and not just having them unnecessarily utilize because they really don't have a home.
Right. So that's my presentation.
Senator DePalma.
Well, question with regards to the APCD, and I'm sure it's a conversation that's too long to take here, but we have to follow up after when they self-insured. And I think I've heard the answer in the past, I don't remember, on why they're not in the APCD, what we need to do to get them in the APCD, because at some point then we have a subset of data. And maybe that subset data is good enough because it's reflective, it's statistically significant and reflective of the total population. I don't think so. So, Senator, Chairman, maybe after this.
Yeah. Going back to both yours and Lisa's point on who's in the database and who isn't, if we as a commission have recommendations, are they just as useful to the patients and the payers and the providers, whether they are in the database or not? Is a recommendation who those who are covered directly by Medicaid, uninsured, or self-insured? Are the recommendations based on the data we get from still a very large demographic just as useful to those other sectors? And unless somebody from one of those other sectors presents us with something that really demonstrates it's not, then I think our best work is done assuming that it is. At least to me. I mean, it's a big enough demographic that I think if we have a recommendation that's good for the one sector that we do have the data from, still a very, very, very large sector, I think it's useful to the rest.
I would just say, to try to answer your question, Senator, as a submitter, Blue Cross is a submitter both as a fully insured, for our fully insured and many of our self-funded. So Blue Cross and Blue Shield of Rhode Island, as an example, has a self-funded employer group health plan. We submit those claims. It is a Supreme Court, U.S. Supreme Court decision that said these laws around APCD data submission are not, they're preempted by ERISA, and therefore it is the choice of the self-funded plan. So many self-funded employers do have their claims submitted. Some have chosen to opt out. Their rationale for that I can't explain, but just as the background.
But also as a payer who does both, do you agree with my initial assumption that if we
agree.
do something on behalf of your insured versus your self-insured, we're probably still making a recommendation that is useful?
Yes, and
to both.
some of those self-funded,
Yeah.
I think the reason they choose not to is they're large populations outside of Rhode Island.
Right.
Right, and so it has been our position through various conversations that this data is representative, and there are some utilization differences based on plan design differences, but I think largely this is representative of what we see and believe it is. I'm so happy to see APCD as a substance for this kind of conversation. Data-driven discussion is critical. So I'm just thrilled to see it as part of a discussion. It has never been in this way. And so I think it's an absolutely great place to start.
So I do want to delve more into, people introduced themselves and kind of skipped over a discussion of issues that we could be discussing based on who you represent or want to represent. If you want to expand who you're specifically representing, feel free to do so. I want to start that, hence the reason for the table is to be more able to do that. And initially, and you can see some of that in who's represented as people involved in the commission, where people that have historically made a case for us that reimbursement rates have had a major impact on their sector, whether it be dentistry or substance use or psychiatry. Some of the reason that some of these people are here is because they have a history of having a very serious concern that reimbursement rates have had an impact on their ability to deliver services to Rhode Islanders. And the Office of the Health Insurance Commissioner, of course, does play a role in that. And we can get to this right away as starting off this roundtable, or and then we can go around. But one of the things, Ms. Ghanem, I was interested in whether, and I want you also to talk as commission members, what you might expect from future meetings and whether you were interested in presenting in future meetings or what you would want to be presented. And one of the things I thought the Office of the Health Insurance Commissioner may or may not be prepared to present, because I think it's a major issue that has an impact on the discussion, is network adequacy. And whether, I know you're studying that, and I don't know if you can give some preliminary information in a future presentation, or just generally what do you think about its appropriateness and your ability to do that?
Great. Well, thank you. Thank you so much. Thanks to everyone. So yes, our office has the responsibility since January 1st of 2018 to look at network plans, or the insurers that have networks that people, their subscribers utilize. And as part of the law and the regulations, it's very clear that the health insurers must maintain networks that allow for ready access, both geographically in terms of hours, in terms of specialty access, et cetera, to the beneficiaries. So we have never done this before, but we are going out, we're in the field right now with an audit, basically. It's a market conduct exam, which is targeted at network adequacy. And there are many pieces and components of that, as you can well imagine. So the first is, are the provider directories that the insurers have, in fact, accurate? When a beneficiary opens up, whether it's on the computer or in their paper provider directory, can they actually get an appointment with the insurance they have to that particular provider? And can it happen in a reasonable period of time, depending upon what their issue is? So that's number one. Number two, we're looking at the credentialing processes. So are, in fact, providers, when they approach an insurer and say, I'm ready to become or interested in becoming one of your credential providers, how quick, how timely is that process? And what is each insurer looking at before they make that determination? Next, of course, it is kind of a geo-mapping exercise. We're going to be using the APCD to the best that we can to determine where the claims are for each insurer, and looking at how they are distributed across the state to see if, in fact, people are having access, or if people are going out of state for certain types of care. So that is going to be very important to us to determine if, in fact, networks are adequate. And then lastly, while it's not part of this first review, if we find there are issues or problems, and hopefully we'll have some general information we can bring to the last meeting of this group. We may have actually some general conclusions, but we won't be able to speak specifically to those because these market conduct exams are very heavily regulated, how we do them. It's for fairness to the insurer as well as to the folks doing the work. And if I were to speak specifically about anything that we find, Monica will sue me instantly. So I will have to be... No. But someone else in the audience will. But if there are general findings that we feel that we can bring forward, we will. But then the process will be, if we do find some issues with specific networks and specific insurers, then we will work with them to address those issues. And then next, if those issues we think are based on reimbursement, and certainly the work of this group will help to inform that conversation. If it's tied to reimbursement issues, then in fact we can go back out and do a review of the reimbursement. And again, the claims data is going to be so helpful there. We won't actually have to ask the insurer for that information, but can review the reimbursement rates through the claims. So yeah, we're very excited about using the APCD too, and we'll be as open as we can through this process.
So one of the things that leads me to is going to why we convened originally. And one of the reasons we convened originally, as I said in my opening remarks, is kind of the convergence of the anecdotal to what we can arrive at through data or be confirmed with data. And so some of the things we've heard over the years anecdotally is the access to a comprehensive range of services, whether it be inpatient or patient or outpatient, and how much of that is driven by reimbursement. And so what I think about when you talk about looking at network adequacy and the way you're able and hopefully going to be able to present is that what we have heard anecdotally, and what representatives and senators often hear is that somebody has to wait to see a specialized care or wait to see an outpatient care to avoid an inpatient care. And so they go to their list of providers in the network of however they're insured, or they go to a community health center, and the community health center wants to refer them to the appropriate specialized care. And the list of people they have either does or does not take the insurance that, first of all, or if they do take the insurance and they are listed in as a provider, they're told that they'll have to wait 6 months, or they'll have to wait a year, or they'll have to wait 9 months. And so is that effective and appropriate? And if that is the case, is it a real network in the way it functions, or is it a network on paper? And so how much is that what we hear anecdotally able to be shown up statistically, and how much does reimbursement have a role in that? Is that network that inadequate or that unrealistic to what we see on paper, driven by the reimbursement rate, and how much is it driven by the reimbursement rate? And therefore, one of the things I'd love to have more information on, and to see if we're accurate in some of our assumptions from those who are kind of make cases based on anecdote, is when we talk about adjusting reimbursement rates so we have a real continuity of care and real network adequacy, we understand that part of that may be an increase in rates for some services. And does an increase in rate really mean an increase in expense? Because if we really have that continuity of care, do we avoid the most expensive by having real access to the less expensive with an increase in rate? Because that increase in rate has avoided the most expensive care. And that gets back to Dr. Sarkar's presentation. Are those the most expensive diagnoses because they have a high inpatient cost? And so can we have a high impact on those most expensive diagnoses by creating better access to more early diagnosis and more early treatment in an inpatient setting? That may be more expensive if we reimburse at a higher rate, but be less expensive systematically because they avoid being one of those, what you see on your list.
I think that'll work, except, I mean, there's the notable exception is actually sepsis, because that starts in the hospital, and so most of the, but I think for many of the other conditions that you end up in the hospital for an acute event, then I think that I think would be where we'd want to sort of be thinking about.
And so I'll try to be quiet because this is meant to be a roundtable, and you've only heard from me and Marie, so anybody else?
I want to say, I think you have your pulse, I mean, you have your finger right on the pulse of this. And the rate increase for reimbursement, I believe, will lower costs, because from my vantage point, when you have primary care physicians that should be seeing these Medicaid beneficiaries, for example, and they've capped their panel out of just survival to make sure that they can pay their bills and keep the lights on, and say, if I go over that critical 25% of my panel being Medicaid, I'm not going to be able to run the business in the way that I should be able to. I think that's when you know that you have a significant problem. And when our providers are getting calls from MCOs after certain providers now will no longer take any more new Medicaid members, or they're dropping Medicaid altogether, they have nowhere to place these members, and it's scary. And it pulls on the heartstrings of our providers, and they feel absolutely terrible about it, and they will call us and say, is there any help that you can give to help place? And we'll begin to hit the phones to talk to providers to say, are you taking any Medicaid lives? And more often than not, you get no, that they're at that critical point in their practice where if they take any more on, then they're going going to struggle in their business model. And so I think that that's exactly where discussion should go, because I think that for that small amount of uptick for a provider to want to be able to, or to be able to take on these Medicaid lives, will save exponentially later down the line, because they're truly being managed. And if they're not in a primary care practice or an FQHC, they're not being managed.
Sorry, I just wanted to mention that the audit that we're doing, the market conduct exam, will not reflect what Dr. Benedict is talking about. It won't reflect Medicaid. It won't reflect Medicare. It won't talk about self-insurance. It's really looking very narrowly at fully funded commercial lives. So if there are, in fact, problems in other funding sources from other payers, it won't be reflected in the work that we're doing.
So could an exception to that be, or could there still be interesting information based on some of our payers are structuring their reimbursement based on Medicaid rates?
It is very possible, yeah. And clearly there is spillover. If there's decreased access because of some inadequate payments, then there may just be decreased access for everyone. So we might see that, yeah.
Thank you. So talking, going to rates and it not being, Medicaid not being included in your market conduct, I know that the Medicaid office at OHHS actually just completed a rate review, and I don't know whether or not, I haven't seen a copy come forward. The Milliman report?
Right, that is, by the end of the year, we should be able to have that where it's shared. So it's being finalized, so like you said, it's complete. But by the end of the year, that should be able to be more broadly shared.
Do you think that any information that you've collected might be able to be brought forward? Like Marie had offered to bring some information forward.
No, yeah, yeah, it'll be broadly through that work group shared. Yeah, but I'm saying it'll be through that broad group, and I also can bring it here. So yeah, inform both things.
What it is, I'm not familiar.
There's been a project ongoing since the spring to comprehensively review using our certifying actuary to look at the behavioral health rates in conjunction with BHDDH. So it's a pretty broad set of assessment on where we compare benchmarked against other providers in other states. So, and I think, but listening to what's being done here, I mean, it is a very complex issue to pull apart of what access problem we're trying to solve. Are we solving a Medicaid access problem because that's part of it, or are we looking holistically at all providers across the state access one? Because as we start to talk amongst ourselves, you begin to kind of outline a very, very complex landscape that, yeah, right.
This requires a certain amount of discipline and like input from the commission, because on what we could focus on. We could
go very broad, or
we could focus on reimbursement and it's only have a commission based on Medicaid and its impact on the rest of the health system and Medicaid's reimbursement rates as it impacts the whole health system overall. We could have a commission, and it all goes under the definition of what this commission could or couldn't do, or could do.
Right.
We could talk only about the impact of potential hospital mergers and what reimbursement rates have an impact to what stays or goes elsewhere in Rhode Island, or what the impact is having right now versus Connecticut, Massachusetts, and Rhode Island versus reimbursement rates in the states and the disparity between those reimbursement rates. We could go a lot of directions. We could focus just on behavioral and have a serious impact. We could focus just on, there may not be dental because of the demographic of our dentists right now is 60 years old or greater, right? So we could have, and that you can't recruit because of the reimbursement
right. I mean, so in terms of listening to Jane, I mean, that was behavioral health and adult dental fee-for-service are
Right.
critical access ones that we
Right.
anecdotally or
Yeah.
data-driven know if it's 60.
So between now,
And I think it's
Yeah.
possible to say, if you look at adult dental, that's the clearest example of what happens when the rates are inadequate. Rates in adult dental fee-for-service for private dentists have not changed in the last 24 years.
right, you
Yeah,
could go
still-
to child psychiatry, and there are only 16 in the state.
Right.
Right, so the burden of this commission is, what do we want to focus on? And because it's now 4:15, I want to wrap up by about 4:30. I want people, the commission members, to think about that and how they want to present, what they're interested in having present if they don't want to present, what they're interested in focusing on, and seeing next, how the next meetings might be structured. So we can hear, we expect to hear again from Dr. Sarkar based on your feedback. We expect to hear from the Office of the Health Insurance Commissioner based on your feedback. But as far as the rest of it goes, I think it's really up to the commission and those who are filtering that information to properly present the priorities. So that gives you an idea of what we could or couldn't do, and I don't want to direct until we hear from commission members on what they think the focus could be or should be for the next several meetings.
I'd like to add to what Noah was saying, is that if we're going to be looking at Medicaid, and some of the panels are closed to Medicaid, it's multifactorial. It's not just the reimbursement rates, but it's also a matter of the fact that these patients do take a little bit more time and they're a little bit more complicated. So I think one of the great things that we're working with the Office of the Commissioner is working on alternative programs that help with making these patients using other, not just the physician, but other providers in the office, nurses, nurse care managers. So some of these innovative models are very successful. So I think if we do look at Medicaid patients and their lack of access, I think we need to look at all of the reasons why these panels are being capped. It's not just the reimbursement rates, it's also multifactorial. As I mentioned, they're very often very complex patients with a lot of comorbidities that we should also look at.
And also one of the things we've heard anecdotally is those complex patients, one of the things that is not currently reimbursed is that case management, and how do we get that case management reimbursed in all cases?
So we're really excited to work with some of our partners on some innovative ways to try to do that.
Yep.
Chairman?
Yes.
You mentioned child and adolescent psychiatry.
Yeah.
16 in the state.
Yeah.
How many of those doctors take insurance?
Right. Yeah. So this is what we're hearing anecdotally.
Right. So it's fact that most don't.
Right.
But we don't have the data.
Yeah.
And we're not just talking Rhode Island, or you do have the data.
No, we will.
You do have?
We will, at least commercial
Okay.
insurance.
So this
And
might
this
be
is
some
not-
of the low-hanging fruit that goes to what I already said, is that if you have better access to child and adolescent psychiatry by adjusting a reimbursement rate, all those children and adolescents who don't have access until they're hospitalized, are they now becoming less expensive patients because we've expanded their access to care before they become inpatient?
And this is not a Rhode Island issue.
Right.
This is nationwide.
Right. So,
And I think this is the value then of connecting the APCD to something like the Health Information Exchange, because the Health Information Exchange is not biased by how you pay and who you pay. It's your health data, and so we would be able to sort of detect the signals of earlier on in one's care if we could link from the APCD what's happening to an individual. We could link back into the clinical data and say, these are the services that they got. We know what we're missing on that side, of course, is what it costs, but we could then make some imputation about access to those services. Certain individuals having access to certain types of services had better outcomes that actually overall impacted the total cost.
So the conversation we just had about child psychiatry is a great example of what we want to get beyond the anecdotal and back it up with some data. And so we can't, it's much easier for us to react legislatively if there's a legislative component to it, if we can back it up with some data, rather than for the last 12 years as I've been here, trying to act on it anecdotally only. And so that's, I think, one of the responsibilities we have here.
We could get the data from Rhode Island.
Right.
Can we get the data from other states?
I think there's enough that we can get to make the case on why it's important to do in Rhode Island.
Okay.
But I want to tell you, one of my priorities in any commission I'm involved in, including this one, is to have public comment. And seeing as we have about 10 or 15 minutes left, I want to make sure that we leave time for public comment and make sure the commission members are left with what I said and what you want, how you want to structure the meetings, and talk to Molly about that and feedback to Molly. If you don't have her contact already, make sure you get it before you leave, on what you would like to see beyond what we've already stated as potential presentations or subject or range of what we discuss. And so with that, I want to, before we close out, see if there's any public comment. The first person, we do have people who have signed up ahead of the meeting to public comment. Tara Hayes.
Hi, good afternoon. Thank you, everybody. Thank you, Chairman, for convening this meeting. I am the Family Voices Manager at Rhode Island Parent Information Network, and I am also the mom to a medically fragile child. And I want to say that I really appreciate this conversation. We at Ripon hosted a policy forum in September where we discussed access issues for families with children with special health care needs. We developed a policy brief, which I did bring, but unfortunately coffee got spilled on them, so they're not available today, but I can get to Molly to share with the committee, because we did find state and national data about access issues around behavioral health care, neurological services and supports, and in-home services and supports, which includes nursing as well as step-downs from behavioral health care programs. We do definitely understand that data, there's a desperate need for data. There isn't enough data in the state, especially to understand the capacity of the state to treat the children and the need of the families and individuals in the state that need the services. So we would definitely like to see that. We would really appreciate, we know that the rate review from Medicaid was great, but we would also appreciate to have the full market conduct review from Medicaid, because we would like to see the network adequacy across all plans in the state, so that we can help to build partnerships with each other within networks to allow families and other individuals to actually get the care that they need. And finally, I just wanted to point out that just 2 days ago, I got the news that New England Pediatric Institute of Neurology has now closed. So we have lost one other institute of neurological testing in the state, leaving families pretty much with a private provider or the CNDC at Hasbro Hospital. So, there's one more access issue that we're going to start facing soon. So I appreciate your listening to me today, and thank you again.
Any questions for Tara?
No, thank you.
Thank you.